Yes. Yes, sir. Okay. Yes, sir. Am I audible now? Am I audible now? Yes. Yes, thank you. A very good evening, everyone, for all the children who have commented. Good evening, good evening. A very, very good evening to everyone. As a part of our Plant C Plus English Platinum Edition, we are coming up with the regular sessions, YouTube live sessions on every Wednesday and Friday. The ultimate key behind these particular sessions is, like initially you will be having a conceptual learning of learning completely about a topic. These topics are curated specifically from the high yield topics which are very important and which are probably asked in your examination. And the topics are undergone the background verification also. We have done a NORCET trend analysis, like which of these questions, which of the topics are frequently asked, or many number of questions has been coming from those topics. These particular topics are curated and I'm coming with the conceptual learning. We are going to learn the completely about that particular condition and in the MCQ point of view, and followed by we are going to quickly have an MCQ discussion followed by this particular session. Yes. Now without any further delay, let's get into the session, and I request everyone, if you have any inconvenience in the audio or in the video, please put in the chat box so that I can come to know. Right? If you have any queries, you can also ask that also. So any guesses of today's topic? It is from the respiratory system. Any guesses for today's topic? Today's topic which we are going to see is the chronic obstructive pulmonary disease. As I was doing about the trend analysis of questions, number of questions from the COPD, in past NORCETs, the number of questions which is asked from COPD is around 8 to 10 questions or asked from COPD specifically. So this particular topic is very, very important, and all the important things has been listed in this particular session. And the most important thing, as you all know, as NORCET trend is keep on changing and changing, they have started asking more image-based questions. Earlier, X-ray findings and all, we don't get questions from that part. But nowadays, we start getting questions from X-ray findings, from all the different scales and scores. So it is very important to go in depth for all the conditions to get the exam cracked so easily. So that's why I have curated this particular classes in a quite advanced manner so that you can explore all the important things which is governing the COPD. Right? As you all know, COPD stands for your chronic obstructive pulmonary disease. So this disease, you have to remember the keyword. Whenever you see COPD, the keyword is irreversible airflow limitation. These three words are very important. As you see, it is an obstructive lung disease. COPD is an obstructive lung disease. What is meant by obstructive lung disease? There will be an obstruction in the airflow into the lungs and then out of the lungs also. So there will be obstruction in the airway and in going inside and coming outside. So that is termed as obstructive lung disease. And you all know, when it is an obstructive lung disease, we have many obstructive lung diseases. Why we have clinically telling it is an irreversible airflow limitation means COPD will not normalize even if you go and give the management also. Even after proper treatment regimen, your spirometry level or the airway will not be re-established. It is always irreversible. But in case of asthma, when you talk about asthma, it is a reversible airflow limitation. Whenever you're going to administer the immediate management of bronchodilators or whatever the medications which is going to be in the management of asthma, there can be an reversible effect of that airflow limitation and the patient can go for good respiration. But in case of COPD, it is an irreversible airflow limitation inside your lungs. Right? This is very important to note in this first slide. And the important thing which you have to note, COPD is always the combination of two important conditions. As you all know, that is your emphysema and your chronic bronchitis. Emphysema and chronic bronchitis. Always remember, COPD is an umbrella term which is governing two conditions, that is emphysema and chronic bronchitis. Right? So you can see this picture, like what is emphysema and chronic bronchitis. Emphysema, always remember, there is an inflation of the alveoli. There is an excessive hyperinflation. You can tell so clinically that it is an hyperinflation of the alveoli, and because of that there is no elasticity, thereby there is poor perfusion and ventilation. On the other hand, we have bronchitis. Bronchitis is a condition, or to be so specific, chronic bronchitis is the condition where there is an excessive mucus production which is obstructing the inner airway, thereby it is restricting the entry of air inside the lungs. Okay, so that is the difference, major difference between emphysema and bronchitis. We will be discussing it in detail. Okay. What is the primary etiological and risk factors of COPD? Whenever there is a MCQ of what is the most common cause of COPD, you have to close your eyes and go and take cigarette smoking. So the most common cause of COPD all over India, all over the world, it is your smoking. Right? Next, we have the additional risk factors. The second-hand smokers are also in the risk. Okay, the passive smokers are also in the risk of getting COPD, followed by the occupational exposure, which means whenever I am occupationally exposed to excessive dust, excessive dusty materials, I am at the higher risk of getting COPD. Right? And one of the other thing is the people who are cooking inside with wood and all. Right? The excessive smoke is also an highest risk of your COPD, right? And air pollution is also one of the additional risk factor for your COPD. And next, the most important thing, and where MCQs are asked, which of the following protein derivative is leading to chronic obstructive pulmonary disease? When there is an MCQ, you have to close your eyes and you have to go and take, it is alpha-1 antitrypsin deficiency. So now in the next slide we are going to discuss what is alpha-1 antitrypsin deficiency. Sorry, before that we will have a quick small review about this COPD and emphysema and chronic bronchitis. So as we discussed, COPD's classical definition is irreversible limitation of the airflow inside the lungs. Now specifically it is an umbrella term, we have been discussing it, and it has two conditions. First is emphysema. So emphysema is irreversible dilatation of the airway from the distal to the terminal. Emphysema is the irreversible dilatation of the airway from the distal to the terminal part, which means from the away part to the end of the alveoli, there is an irreversible dilatation of the airway, which in turn is termed as the inflation or hyperinflation of the alveoli. So in emphysema we have three types. In emphysema again we have three types. First is the centriacinar. Which is the most common type of emphysema, which means this is the alveoli. And there is a dilatation in the center part, that is termed as centriacinar. Okay, these are acinars. Okay, these are acinars in the alveoli, and we are terming it centriacinar when this hyperinflation is happening in the center. Next we have pan-acinar. Whenever you see a word pan-acinar, pan-India, which means all over. Right, it means all over. For example, again if you talk about this acinas, here everywhere there is a dilatation, and hyperinflation, that is termed as pan-acinar. Next we have distal acinar. Distal acinar means, again we are considering this as acinars. Here at the end there will be dilatation. At the end of each acinars there will be dilatation, and it will be very much irregular. That is termed as distal acinar emphysema. So we have three types of emphysema, that is centriacinar, panacinar, and the distal acinar. Centriacinar, as the name implies, the central dilatation will be there, and panacinar, it will be all over the particular acinar, and followed by the distal acinar, that is in the distal region. Distal region means what? It is far away from the body, right? So in the corners, in the end of the alveoli, there will be the dilatation. That is termed as distal acinars. And the MCQ point which you have to note is, which of the following emphysema is the most common emphysema? When there is an MCQ, you have to go and take centriacinar. And if they are asking an MCQ about specifically about alpha-1 antitrypsin, it will be a generalized question. When they are making the question paper more tough, then they will be asking this kind of questions, right? So you have to tell panacinar is the one which is most commonly caused because of alpha-1 antitrypsin deficiency, which is a genetic codominant kind of condition. Right. So next is the distal acinar. Next we will come back to the chronic bronchitis. So what is chronic bronchitis? The chronic production of cough. The chronic production of cough with sputum for the 3 months in a year. Okay, for 3 months in a year, and it is for the 2 consecutive years again, which means I have a chronic productive cough. I have a chronic productive cough for the 3 months, continuously for the 3 months in a year I'm having. For the next consecutive 2 years also I'm having this kind of symptoms without any other conditions. I'm trying to diagnose it. There is no other history of any other conditions, but I'm keep on getting these symptoms. Then you are suspecting the patient is having chronic bronchitis. So next we are going to talk about the pathophysiology, which is relating to your alpha-1 antitrypsin deficiency specifically. First and foremost, you have to understand there is a word here, anti. Okay, so what is the role of alpha antitrypsin? What is the role of alpha antitrypsin? Sorry, you have to note the word deficiency, not anti. Okay, you have to note the word deficiency, not anti. So what is alpha antitrypsin? Alpha antitrypsin is one of the important protein component. Okay, alpha antitrypsin is one of the important protein component which protects the wall of the alveoli with the elastin component. Okay, it is used see the capillary walls. The capillary and the alveolar wall is having an elastin component, and this particular elastin component is protected by your alpha-1 antitrypsin. So because of the condition, because of the preceding conditions such as smoking and exposure to various smokes and all, what happens? Your mechanism of macrophages and neutrophils will start activating, and it causes protein and protease and antiprotease mechanism, which will lead to destroying of this elastase component, which will lead to restoration of the elastase component. So this alpha antitrypsin, what it will do? It will reduce this elastase. Okay, this will reduce this elastase. To be very clear, I am telling it from the first. First is, alpha-1 antitrypsin deficiency is causing COPD, right? So first and foremost component you have to understand is the capillary and alveolar wall has elastin, which for the elastic recoil. So this elastin is protected from the component alpha antitrypsin. Okay, it is protected from the alpha antitrypsin. So what happened in this case is, because of the activation, because of the risk factors and triggers, what happened? These macrophages, neutrophils, proteases, antiproteases, everything is activated, and it is damaging, and it is producing elastase. Okay, and it is producing elastase. Elastin is the component which is protecting, and elastase is the component which is destroying this elastin, So if alpha antitrypsin is there, this elastase, okay, this elastase will be described. This will be will be demolished. But in this case, it is not happening. So what happened? Because of this deficiency, freely this elastase is damaging the elastin, thereby the recoil of the alveoli, the stiffness of the alveoli is not mentioned. Alveoli is always maintaining an elastic recoiling capacity where it promotes it being a media for taking the air inside and leaving it out with a good number of pressure. Right. So in this case, if this elastic fiber which is surrounding the alveoli is damaged, what will happen? It loses its elastic recoil and it will become even more big and overinflated. So first and foremost thing you have to remember is alpha-1 antitrypsin deficiency causes COPD, but what is the specific effect is? We have the elastic recoil membrane in the alveoli, which is produced by your elastin. So this elastin maintenance will be done by the alpha-1 antitrypsin. When this elastase is decreased, which means this elastase will be produced because of the protein mechanism, and this elastase will kill these elastins. Thereby, if elastase is decreasing, what will happen? There will be excessive destruction of the alveoli. So next we have the environmental factors. So these environmental factors such as smoking, non-smoking, and indoor and outdoor pollutions, all kind of pollution, what it is causing? It causes inflammation of the macrophages and the neutrophils. Inflammation of the macrophages and the neutrophils. This in turn release of elastase and matrix metalloprotein. This elastase is going to damage the elastin. Thereby it is causing the recoil to thin. Voice is late behind. Okay. Okay, then what happens? Once this metalloproteinase and matrix metalloproteinase, everything is released, what will happen? It ultimately destroys the elastin in the alveolar wall and it damages the capillary alveolar unit. So ultimate thing which you have to notice, simply what is happening? The damage of the elastic fiber is happening and thereby the complete compression, like the pressure which is maintained in the alveoli is getting loosed and the alveoli is becoming unstiff, okay, without any elastic component. So next, in emphysema and in chronic bronchitis, what is happening? So first, in emphysema, as we discussed, because of this loss of elastic fiber, loss of alveolar wall, which in turn gives the chance of less gas exchange and less surface area for the exchange of gas from the alveolar to the capillary, right? What happened? The deoxygenated blood will be traveling from the pulmonary artery to your lungs. So what happened? The alveolar gas exchange will be taking place where in the alveoli, okay, the O2 will be done and the CO2 will be going out. So here in the in the capillary bed, this transmission of O2 will be taking place. So when there is a less surface area and the alveolar wall is damaged, this in turn causes less gas exchange. So loss of elastic recoil, which means the pressure which the alveoli has to maintain is disrupted. This in turn causes air trapping and difficulty in exhaling. Air trapping and difficulty in exhaling, which means normally the alveoli should be in this size. So because of this elastic fiber damage, so what happened? The alveoli is becoming overinflated. So when it is becoming overinflated and there is no internal pressure is also maintained, so it will be becoming more difficult. The air is trapped here. It will be becoming more difficult to expel this air outside. So that is what is termed as difficulty in exhalation and air trapping. Next we have this lung hyperinflation. Once every alveoli is losing its elasticity and it is causing hyperinflation, obviously you will be having a clinical symptom of barrel chest, which is a very, very important clinical sign which you have to note. Okay, which is a very, very important clinical note. So what is the role of alpha-1 antitrypsin? See, alpha-1 and antitrypsin, normally what it does, it reduces the elastase. Okay, alpha-1 antitrypsin, actually what it does is it reduces the elastase. And if it is reducing the elastase is the component which is causing, see, first and foremost, I think Everything is so confused. Let me start from the first. So listen, elastase is the component. Okay, elastase is the component. Okay, which is damaging the elastin. Elastin is a protective component, good component. Elastin is the good component. Okay, elastin is the good component which is involved in maintaining the good airflow, good elastic recoil. Elastin is the one which is involved in maintaining the good elastic recoil. So what happened? This elastase is the component which is a negative component, and this is a positive component. Please remember this. Elastase is the negative component. When this elastase is getting activated? This elastase is getting activated when there is a risk of exposure to all the conditions which we have seen, the risk factors which include smoking and environmental factors and all. This in turn will activate the macrophages, neutrophils and everything. This will promote the production of this elastase. Okay, this will promote the production of this elastase. So what happened? This elastin fiber, which is a good fiber, which will be damaged because of this elastase. So to reduce the number of elastase, this alpha antitrypsin is used. To reduce the number of elastase, okay, to reduce the number of elastase, okay, alpha antitrypsin is used. Alpha antitrypsin is involved. So what is happening? Just the negative feedback mechanism is started. So what is happening is when this alpha antitrypsin is deficient, what will happen again? This alpha 1 antitrypsin deficiency, what will causes? It will causes the sorry for the interruption. To reduce the number of elastase, alpha antitrypsin is present. So when this alpha antitrypsin is absent, what will happen? This in turn going to cause more elastase and there will be more destruction of the elastin. There will be more destruction of the elastin. I hope it is not, screen is not visible. Oh my God. Once again, what happened to Abhishek sir, the screen has become broader. Ha.
I think your panel, you touch your panel and zoom it.
No sir, like the outside things are visible.
Okay, I'm
Ha ha. Yes, 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 the screen is getting altered. Please wait for some time. visible. Yes, am I audible also? Am I audible also? Okay, fine. Shall we start? Okay. Am I audible also? Yes. So first and foremost thing, what is the role of alpha-1 antitrypsin in the pathophysiology of your COPD? So first I said we have an important component, that is elastin, which is a good component. Elastin is the good component we have. Elastin is the good component we have, which is helping in maintaining the elastic recoil of the alveoli. Okay, which is helping in maintaining the elastic recoil of the alveoli. So now we have a component called elastase. This elastase is a negative component. Elastin is a positive component and elastase is the negative component. So what this elastase will be activated because of the macrophages and neutrophil mechanism which is happening because of the risk factors. So only then this elastase will be activated. What this elastase will do, this elastase will damage, see, you can see here in the picture, this elastase will damage this alveoli walls and this causes the elastic recoil to disrupt. There will be destruction of the alveoli elastic membranes by this elastase, right? So this particular alpha antitrypsin, what it is actually doing is, this alpha-1 antitrypsin will reduce the elastase. See, this elastase is a negative component. When alpha antitrypsin is reducing this elastase, what will be happening? This protection of the elastin will be there. If the elastin is protected, what will happen? The alveoli capillary membranes will be saved. Okay, will be saved and they will not lose their elastic capacity. Is it clear now? Is it clear now, or you want me to repeat it one more? I can repeat it. Shall I repeat it one more? Yes. See, this will be the last. I'll repeat it one more so that you will get a clarity and why this alpha-1 antitrypsin is involved in this. So first and foremost, you have to remember elastase. Elastase is the negative component. Elastase is a negative component. Okay. Please zoom in. Okay, fine. I'll repeat it. See, first remember about elastase. Elastase is a villain. Okay, elastase is a villain. It is a negative component. Elastase is a negative component. So why this elastase is involved? Because of the risk factors, because of the causes, what happens? The macrophages, neutrophils, everything are activated. Okay, neutrophils, your protease, everything is activated and this elastase is coming into the alveoli. This elastase is coming into the alveoli. We already have a good component in the alveoli. We already have a good component in the alveoli that is termed as elastin. That is termed as elastin. We already have this good component, that is your elastin. Okay, this is a good component which is protecting the alveolar membrane to maintain its elasticity. Elastin maintaining elasticity. Okay, yes, smoking is one of the causative factor. So this elastin is a positive factor which is involved in protecting this elastic recoil of the alveoli. So because of the triggering factors, when elastase is activated, this elastase will directly have a negative effect of this elastin, will have a negative effect on elastin. This elastase will have a negative effect on elastin, thereby it causes damage to the alveoli. Damage to the alveoli. I hope you understand now. Damage to the alveoli. Once this elastin is getting distracted because of the elastase activation, the alveoli is going to get damaged. This is the mechanism which is happening. So if alpha antitrypsin is present, if alpha antitrypsin is present, what it will do is, this alpha antitrypsin will decrease this elastase. The normal function of the alpha antitrypsin is to decrease the elastase. If it is decreasing the elastase, it is not going to disrupt any actions. It is not going to touch the elastin. So this damage to the alveoli will be prevented. So that is what is the role of the alpha antitrypsin. Okay, that is the role of alpha antitrypsin. So next we go into the next particular conditions which we are seeing. So as we have seen, the loss of alveolar wall, which is going to lead to decrease in the alveolar gas exchange, and thereby it is going to cause lung inflation. Because of the loss of elasticity, what happens? The lung is the alveoli are hyperinflated, and this in turn causes the barrel chest, which means normally the alveoli should be in this particular size, and because of the loss of elastic recoil, it is becoming this much big size. That's why the patient is exhibiting barrel chest. That is the expansion of the anterior posterior diameter of the lungs. So on the other hand, when you come back to chronic bronchitis, it is a globular cell hyperplasia. The important and foremost important thing you have to notice, in emphysema, the problem is in the recoil and there is hyperinflation. But in case of chronic bronchitis, what happened? The airway is obstructed because of the excessive mucus production. The airway is obstructed because of the excessive mucus production. Why this excessive mucus production is happening? This excessive mucus production is happening because of the globular cell hyperplasia. Okay, so this in turn makes the airway so narrow for the air to enter inside. In a normal airway, there is a good number of space for the air to go inside and outside. But in this case of chronic bronchitis, because of the globular cell hyperplasia, there is an excessive amount of mucus production, and the mucus is settling inside in the inside area of the alveoli, which in turn causing the airway to get narrowed, which means it is concised or constricted, and it causes further symptoms. Next is bronchial wall thickening and narrowing of the airway is happening, and productive cough due to mucus. Because of the hyperplasia of your globular cells, there will be excessive production of the mucus. This mucus in turn, what it is doing, this mucus in turn is giving the productive cough. And you can ask me why I have written emphysema and chronic bronchitis in a different color. Always remember, emphysema is otherwise known as pink buffers. Okay. Emphysema is otherwise known as pink buffers, and your chronic bronchitis is known as blue blotters. So next we are going to see about the important MCQ points which we want to going to discuss. Before going into it, I would like to have a review about the normal lung volumes. Okay. See, this is the normal lung volume chart. Okay, this is the normal lung volume and capacity chart. So first and foremost, this side we are going to concentrate, that is lung volumes. In this side, we are going to concentrate about lung capacities. Before coming about the lung capacities, we have to learn the normal lung volumes. Okay, so this is an example of a normal adult male. So first and foremost, you have to remember is the tidal volume. Okay. This is the tidal volume. This is the tidal volume. What is meant by the tidal volume? The amount of air present inside the lungs during your normal inspiration and expiration is termed as tidal volume. That is almost 500 ml. This is the tidal volume. The amount of air which is going inside the lungs during the normal inspiration and expiration is termed as the tidal volume. So next value which you're going to see is when I'm having excessive inspiration, when I'm forcefully inspiring more air, like that, if I'm inspiring more air inside my lungs, that is termed as inspiratory reserve volume. So this is the inspiratory reserve volume. Okay, this is the inspiratory reserve volume. From the normal level, I'm trying to even more forcefully inspire more amount of air into my lungs. That is the inspiratory reserve volume, and the value is 1900 ml. Okay. Next, we have to see the same way I'm forcefully exhaling more amount of air. I'm forcefully exhaling more amount of air, which means I'm putting more amount of air outside. I'm exhaling more amount of air. That forceful expiration of the air outside, okay, voluntary expiration of forceful air, and this is that termed as the expiratory reserve volume. This is termed as your expiratory reserve volume. This is termed as your expiratory reserve volume. Even after the forceful exhalation, of air outside my lungs, I always have a minimal amount of air inside my lungs. That is termed as the residual volume. That is termed as the residual volume. The important volumes you have to remember, first is the tidal volume, which is the normal amount of air present inside the lungs when there is a normal inspiration and expiration. That is your tidal volume. When I am forcefully inspiring more amount of air, that is called as what? Inspiratory reserve volume. That is, this particular graph is showing your inspiratory reserve volume. Next, I am forcefully trying to exhale more amount of air. That is termed as expiratory reserve volume. Next, at last, even I'm forcefully exhaling the more amount of air outside, there is always some amount of air which is retained inside the lungs. That is termed as your residual volume. Your alveoli is not like a balloon. It is not like a balloon, like once you put all the air outside. It is not like that. There is always some amount of air which is maintained inside the alveoli, which in turn promotes the input and output of the air. Okay, that is termed as your positive end expiratory pressure. Even after forceful expiration, there is always some amount of air which is remaining in the alveoli to maintain that elasticity and to maintain that particular recoiling capacity, right? So that is termed as your residual volume. Now coming back to the capacities. Till now we have discussed about the volume. All these we have seen. Your inspiratory reserve volume, your tidal volume, your expiratory reserve volume, and your residual volume. Now coming back to the capacities, which means the important capacities of your lung. First and foremost, you have to learn about the inspiratory capacity. The inspiratory capacity, okay, your inspiratory capacity is this, but it is not that much important, no need to concentrate on that. First, you have to learn about the vital capacity. You have to learn about the vital capacity. The vital capacity, what is the formula for vital capacity? You have to tell so clearly. Vital capacity of the lungs is your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume. That is your vital capacity. Your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume is your what? Vital capacity. The next important thing you have to know, the next important thing which you have to note is the functional residual capacity. That is in term shortly mentioned as FRC, functional residual capacity. Vital capacity is very important because we are going to talk about forced vital capacity. Okay, so it is very important to note. Okay, it is very important to note. Very good, Rapa, you are answering everything in advance. Very good, very good. So here we have the forced residual capacity. Your forced residual capacity is the combination of your expiratory reserve volume plus your residual volume. Your FRC is your expiratory reserve volume plus your residual volume. Okay, your FRC. So next we have the total lung capacity. Obviously, the total lung capacity will be your IRC plus TV, tidal volume plus ERC plus your residual volume. So that is your what? Total lung capacity. So the total lung capacity, the important vital capacities are very important to note to learn about your COPDs. COPDs, clinical manifestations. So here we have what are all the things, what is happening in the changes in the lungs. So from this area the question will come. First of all, just remember the forced vital capacity. We have learned about the vital capacity. What is the formula for vital capacity? Vital capacity is your first is your inspiratory reserve volume. Vital capacity formula, please tell me. Your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume is the vital capacity, is your vital capacity of the lungs. So what is happening? The forced vital capacity will be monitored by your spirometry, or it will be monitored by your PFT, pulmonary function test. Okay, your forced vital capacity will be monitored classically by your pulmonary function test. Next, you have the residual volume. First we have to see the changes which is happening, because in the forced vital capacity, the forced vital capacity is decreased in case of COPD. The forced vital capacity is decreased in case of your COPD. So it is not always classically decreased. It is not always classically decreased. Okay, it is definitely the forced vital capacity is decreased. Yes, barrel chest is seen in COPD. Okay, the forced vital capacity is sometime normal or sometime it is decreased. It is always variable. Sometime it is normal or sometime it is decreased. Next, we have the residual volume. The residual volume is always increased in case of your COPD. Why the residual volume is always increased in case of your COPD? Because the alveolar elasticity is not maintaining, so that what happened, there will be excessive amount of air trapping, which in turn causes the excessive amount of air will be settled inside the lungs. That's why there is an increase in the residual volume. The total lung capacity, if the residual volume and if the vital capacity, everything is increasing, obviously what will happen, there will be increase in the total lung capacity. So what about this diffuse capacity, your DLCO? Diffuse capacity is the diffusion, okay, is the diffusion capacity of the lungs for carbon monoxide. So your DLCO is the diffusion capacity of the lung for carbon monoxide is decreased in case of your emphysema. So first you have to know what is meant by DLCO. DLCO is the diffusion capacity of the lung for carbon monoxide, which means this test is administered by means of administering the carbon monoxide, and this test basically tells how much the alveoli and the capillary membranes perfusion, oxygen exchange is happening effectively. That will be analyzed by this particular test. That is your diffusion capacity of lung for carbon monoxide. This is done by carbon monoxide because it has increased affinity towards hemoglobin. So that's why this test is performed with the carbon monoxide. So basically, what you have to remember in this, DLCO is done to identify whether there is a proper gas exchange, the O2 exchange which is happening properly between the alveoli and capillary or not. That is monitored by this DLCO. Since this DLCO, obviously the surface area of the alveoli is increased and everything is disrupted completely, obviously the DLCO will be decreased in case of your emphysema. So next, the most important clinical value which you have to note whenever we are talking about this COPD is your forced expiratory volume 1, that is forced expiratory volume, which is expressed in the first second of the exhalation in your pulmonary function test, and the FVC. FVC is the forced vital capacity, the total volume of forcibly exhaled after a deep inspiration. The total volume of air which is forcibly exhaled after a deep inspiration, that is the forced vital capacity. When we are monitoring this forced vital capacity, what will happen? We will be monitoring this FEV1. So when consider in the PFT, you are doing the FVC calculation. So it is 5 letters. Okay, the forced vital capacity, that is the total volume of air forcefully exhaled from the lungs after a proper inspiration, after a deep inspiration. So this FEV is the forced expiratory volume in 1 second. Okay, the volume of air exhaled in the first second of the forced expiration, which means I am starting my forced expiration. During the first second, this forced expiratory volume 1 will be analyzed. That is why it is written 1 here. So consider your normal FEV, FVC, FE1 ratio. Okay. So this FEV 1 is 4 liters. So obviously the normal value of your FEV1 and FVC ratio is somewhere around 0.75 to 80, or normally if there is a classical question, you have to write it is 80%. Okay, it is 80%. Okay, so that is the normal FEV FVC ratio. When we are telling this FEV, when we are telling the patient is going for COPD, can anyone tell me like what is the normal FEV FVC ratio we have discussed? What is the ratio we are diagnosing the patient as COPD? We are diagnosing the patient of COPD when the FEV FVC ratio, okay, when the FEV1 and FVC ratio is less than 70. Is less than 70%, we are coming to the conclusion that the patient is going for the COPD. We are concluding the patient is going for COPD. Next we have the FEV1. This table is indicating in case of COPD, what is the finding? In case of COPD, what is the finding? So the first thing you have to remember, FE1 is reduced. Always remember FE1 will be markedly reduced, because what is FE1? Like the elasticity of the elasticity is not maintained, and the bronchioles is full of mucus and materials. I cannot exhale properly. So that's why what happened, there will be marked reduction in the FEV ratio. What about FVC? The forced vital capacity, as we discussed earlier, it may be normal or it may be decreased. Sometimes it will be normal or it may be decreased. On the other hand, the FEV FCC ratio will be less than 70%. So we are completely coming to the conclusion, now the patient is going for COPD. So next we have the compensation patterns. Okay, what are the compensation patterns you have to remember? As I said, you emphysema or pink buffers and your bronchial asthma, your chronic bronchitis is the blue blotters. So what are the compensation patterns you can see? The emphysema patient, they will be craving for air. They will try to do maximum inspiration and expiration kind of activity. They will struggle for breathing. Okay, they will struggle for breathing. So because of that, they will be having excessive weight loss. That's why the patient is looking thin, and they will be having breathlessness, and there will be no cough. Here you have to understand the patient is not having any excessive mucus production in case of emphysema, so there will be no cough. And the patient will be having hyperventilation. They will be keep on craving for air more and more, because already there is a lot of residual air which is present inside the lungs, and the gas exchange is not happening properly. So what they will do, they will try to hyperventilate themselves to maintain the oxygen saturation. So they will be having recurrent hyperventilation, right? So to maintain the O2 level, they will be having excessive hyperventilation. Now what happened? The PaO2 level will be normal in case of emphysema, and the PaCO2 level is lower in case of your emphysema. Okay, this is coming under your emphysema, and there will be increased work of breathing, and late cor pulmonale will be seen. So there will be increased work of breathing. The patient will be trying to keep on breathe and even more to breathe, so that they can ventilate themselves and to maintain the saturation. So later what will happen? This will lead to pulmonary hypertension, and the patient may go for cor pulmonale, but this happens in later stage. When the condition is becoming very, very severe, this happens in later stage. On the same hand, coming back to blue blotters, that is your chronic bronchitis compensation. Here the patient will be having excessive mucus production, and the physical examination findings will always tell the patient will be overweight and he will be cyanosed. Cyanosed because there is lack of oxygenation, because there is a narrowing of the airway and there is a lack of oxygenation. What will happen for those patients? The patient will be looking overweight and the patient will be cyanosed, and there will be chronic productive cough. There will be chronic productive cough, as we were telling, because of the excessive mucus production. The globulate cell hyperplasia is there. Because of that, what is happening? There will be chronic productive cough, which means it will be having the sputum. And here the patient will be definitely having the reduced PaO2 level and the increased PaCO2 level. And the patient will be going for chronic respiratory failure in case of your blue blotters, that is your bronchitis, chronic bronchitis. Next we have polycythemia. So what happens when there is a deprivation in the oxygen? This will sense and activate the mechanism in the body where the bone marrow start to produce more amount of RBCs, which in turn going to lead to polycythemia. And this will again, what happened? This in turn again the RBC production will be more, and there will be more craving for oxygen again and again. This will lead to chronic hypoxia for the patient. Next, early cor pulmonale will be happening in case of, when there is an MCQ, when late cor pulmonale is happening, okay, your answer will be emphysema. When early cor pulmonale is happening, your answer will be your chronic bronchitis. Your answer will be chronic bronchitis. So this is all about this. Why early cor pulmonale is happening? Because of excessive craving for oxygen, the respiration is not happening properly. So what will happen? The body tries to compensate and compensate and compensate. And what will happen? The pressure towards your pulmonary veins and pulmonary artery will be getting increased. This in turn going to cause pulmonary artery hypertension. Then the pulmonary system will be overworking and it will be leading to the right side heart failure. So next, on exercise. So these are possibly asked in your examination. What is the exercise response to emphysema and chronic bronchitis? So since the patient is already on hyperventilation in case of emphysema, okay, if the patient is doing exercise, okay, there will be always limitation in emphysema patients. I have an overinflated lungs and I'm maintaining the breathing like this, and the patient will be doing pursed lip breathing, right, in order to delay or in order to make the exhalation more prolonged. Okay, they will be doing pursed lip breathing. So this patient will go for desaturation when they are involved in exercise. Okay, so this craving cannot be attained, or this hypoventilation will be persisting and this patient will be going for desaturation. This desaturation is termed as VQ mismatch and worsened during the exercise. The ventilation and perfusion ratio will be worsened in emphysema patients and the patient will go for hypoxia. On the other hand, in chronic bronchitis, the airway is constricted. Okay, this airway is constricted. Whenever something is promoting the airway dilatation, okay, the bronchodilation, the oxygen saturation will be improved in case of your chronic bronchitis. So here you can see the airway caliber will increase. The airway caliber will increase because of the activation of the sympathetic nervous system. The airway caliber is going to increase because of the activation of the sympathetic nervous system. What will happen on the other state? Emphysema, there is desaturation. On the other hand, you have to classically think in chronic bronchitis, if the patient is doing exercise, their airway is going to be improved. How it is improving? The activation of the sympathetic nervous system is done. This sympathetic activation will improve the ventilation and the VQ mismatch will be decreased. The ventilation perfusion ratio will be reduced. Sorry, the ventilation perfusion ratio will be managed properly and managed effectively. Okay, and what happened? The PaO2 level will also increase. The PaO2 level will also increase. So in case if they are asking anything which is responding to the exercise, like an emphysema, there might be some image based questions. Okay, image based questions where they are going to, sorry, not image based questions, scenario based questions, where they will be asking an emphysema patient is performing an exercise and what will be their PaO2 outcome. What you are going to answer? The PaO2 outcome is going to decrease and the patient will go for hypoxia. The same case they are going to tell you a patient with a chronic bronchitis is having a good exercise. What is their effect on the VQ, the ventilation and perfusion ratio? So you have to remember, in case of chronic bronchitis, the airway is narrowed. Okay, the problem is in the narrowing of the airway. But in case of emphysema, it is totally different. Here, this narrowing can be rectified when there is a bronchodilation, right? So this bronchodilation will be achieved because of the activation of the sympathetic nervous system when the patient is doing exercise, which in turn going to cause ventilation, perfusion, proper ventilation and perfusion, thereby increasing the PaO2 level. So next, the clinical manifestation, where the questions mostly asked MCQ part is the clinical manifestation part. So first, cough and sputum is specifically seen in chronic bronchitis. That's why I have mentioned it in the blue. That is your blue blotters. Next, dyspnea is commonly seen in your emphysema, barrel chest. The increase in the anterior posterior diameter of the lungs has happened in case of your emphysema only, not in case of chronic bronchitis. In chronic bronchitis, the patient will be complaining, I have excessive cough and sputum production. But in case of emphysema, the patient will be telling, I am dyspneic, and the patient will be having the increased anterior posterior diameter of the lungs because of the overinflation and hyperinflation of the alveoli. And next point is decreased diaphragmatic excretion. Now you have to know what is meant by diaphragmatic excretion. See, the diaphragm will vertically move forward and backward during inspiration and expiration. If you take a deep inspiration, it will move. How it will move? If you take an inspiration, the diaphragm will move upward. If you take an expiration, the diaphragm will move downward. Right. So this particular movement will happen synchronously in a normal patient. In case of a patient is an emphysema, the diaphragm is flattened. Here the diaphragm is flattened. This in case, what it will do, the excretion, the vertical movement of the diaphragm will not at all take place. Okay, the vertical movement of the diaphragm will not at all take place, which in turn going to cause decreased diaphragmatic excretion. Diaphragmatic excretion is the vertical movement of the diaphragm forward and backward during expiration and inspiration. But in this case, the diaphragmatic excretion is not going to happen, and it is going to happen in the reduced manner because already the diaphragm is flattened because of the overinflation of the lungs. Next we have Hoover's sign. The most important sign which you can get possible MCQs from COPD. So Hoover's sign is the inward movement of the lower ribs during inspiration. In the normal condition, your lower ribs, what it will do, in normal condition, your lower ribs will move outward during inspiration. So when this is not happening and this is happening in an opposite manner, we are terming this sign as Hoover's sign. Because of the hyperinflation of the lungs, because of the overinflation of the lungs, the diaphragm normal movement is the lower lips will be moving outward in case of inspiration. Now practically do an inspiration, obviously your ribs, your lower ribs will try to expand to give a good space while inspiration, right? So in this case, because of already there is an hyperinflation, this Hoover's sign is seen where the diaphragm will try to, the inward movement of the diaphragm will be there. So that is termed as your Hoover's sign. This inward movement of the inward movement of your lower ribs during your inspiration is termed as your Hoover's sign. Whenever in normal findings, the lower ribs will be moving outward, but in case of your Hoover's sign, your lower ribs moving inward during inspiration. That is the classical sign you have to see. Next we have hyperresonance. Hyperresonance percussion note. Whenever there is excessive amount of air inside the lungs, you can see this You can see this whenever there is an excessive amount of air inside the lungs, you can see this hyperresonant percussion sound. Hyperresonant percussion sound. So investigation of COPD, first and foremost, your spirometry in combination with your pulmonary function test, where your FE1 FVC ratio will be less than 0.70, or you can tell less than 70%. Less than 70%. So the gold standard diagnosis is your FEV1 and FVC ratio, which is going to be less than 0.70. Important question point you have to note, which confirms the airflow limitation in the alveoli. So bronchodilators reversibility testing helps to differentiate COPD from asthma. As I said, you both COPD and asthma are obstructive lung disease. So whenever you are giving bronchodilators, the asthma patient will be reversing their airflow limitation, but your COPD patients will not reversed from the symptoms. So that's how you can differentiate the patient as a COPD patient or the asthma patient. So atrial blood gas analysis, just remember which atrial blood gas and which particular ABG finding is seen in COPD patients. Because of the hyperventilation, the patient will be going for respiratory acidosis. Whenever you think about COPD, think about respiratory acidosis. Respiratory acidosis. Respiratory acidosis. So chest X-ray, very important question part to note in case of your COPD. First and foremost thing, as I said you, there will be hyperinflation of the lungs. You can see there is a hyperinflation of the lungs, and you can see the flattened diaphragm. Okay, hyperinflation of the lungs, overinflation of the lungs. See, the lungs is occupying all the cavity. So this is termed as hyperinflation of the lungs, and there is a flattened diaphragm. The important keyword you have to note is hyperinflation of the lungs, hyperinflation of lungs, followed by your flattened diaphragm. Flattened diaphragm. Okay, flattened diaphragm. So next we have the chronic bronchitis. In chronic bronchitis, we have an important classical term. Okay, in chronic bronchitis, we have an important classical term. Am I audible? Am I audible? Okay. Now the screen is visible. Now the screen is visible. Yes. Okay. So now we are going to see about chronic bronchitis X-ray findings. The classical, okay. So the chronic bronchitis classical image findings is, so in case of emphysema, you seen there is an hyperinflated lungs, and you have flattened the diaphragm because the lungs is overinflated. Okay, the diaphragm which is holding the lungs will be flattened like this. But in this case of chronic, the important thing which you can see is the bronchovascular marking. What is meant by blue blotters? Here the lungs is trying to maximally crave for more amount of O2, and the pulmonary circulation, everything is involved in this component. So what happened, there will be more visibility of your bronchial vessels, bronchioles, and your lung vessels. Your lung blood vessels and the bronchioles will be more visible. So you can see the scattering pattern here and there. That is the, you can see the scattering pattern here and there. That is, see, you can see the scattering pattern. That is termed as the bronchovascular marking. The most important key point you have to note is the bronchovascular marking. In case of emphysema, I will have hyperinflated lungs and flattened diaphragm. But in case of chronic bronchitis, I will be having bronchovascular marking. See, you can see a lot of white patches, which is indicating the effective, like the bronchiole is trying hard to do. Okay, the bronchiole is trying hard to do. Okay, and that is the visibility of the bronchioles and the lungs blood vessels. Okay. So next, this is the important thing again, the gold classification of COPD, very important. Whenever the patient is having the reduced less than 0.7 FEV1 and FVC ratio, we are classifying the patient to gold classification. So this is similar, like whenever it is less than 70%, we are coming here, right? So you have to see the most important predictor value which you are seeing is the FEV1 specifically. Okay, FEV1 specifically. So mild gold 1 classification, it is greater than or equal to 80. Moderate gold 2, it is when it is 50 to 80. Severe gold 3, it is 30 to 50. The FEV value is 30 to 50. Then in case of very severe, that is gold 5, that is less than 30. Okay, mild is greater than or equal to 80. Moderate, that is coming under gold 2, it is 50 to 80, and severe, that is gold 3, that is 30 to 50. Then we have very severe, that is less than 30. Next we have the COPD assessment test. Okay, that is CAT, COPD assessment test. This CAT is the questionnaire. Okay, for example, this is like a Likert scale questionnaire. I never cough, I cough all the time. Like the patient has to give the score from 1 to 5 of 8 and 8 questions, which is targeting from the I never cough, I cough all the time, and each question carries the max. Okay, when the patient is getting more than 10, there is a good quality of life. When she is getting less than 10, there is a very poor quality of life. So next we have this Modified Medical Research Council dyspnea scale, the most important scale. Modified. Okay, next we have this Modified Medical Research Council dyspnea scale, that is the MMRC breathlessness scale. Okay, from grade 1 to 4 it is given. I only get breathlessness with sternus exercise, 0 grade. 1, I get shortness of breath when hurrying on a level ground or walking up an hill. And level 2, grade 2 is on level ground, I walk slower than people of the same age of myself. 3 grading you will give, I stop for breath after walking about 100 yards or after a few minutes of level ground. And 4, I am too breathless to leave the house, or I am breathless when I am dressing. Okay, these are limitations. And this is as per the FVC and Gold's criteria and MRC criteria. They are categorizing the patients into A, B, C, and D. So if you take the A patient, their MMRC score is around 0 to 1, and the CAT score is greater than 10, which means the patient is in the good quality of life, and they have not attended the hospital admission because of this breathlessness. So they are coming under category A. Next we are coming to category B, where they are coming under the second grade in the MMRC score, and the CAT score is also what is happening? Sorry, the CAT is less than 10 here, the CAT is greater than or equal to 10 here, and the patient has not visited the hospital. So they are in the B category. Next we have the C category. In C category again, the MMRC score is the patient has gone to hospital greater than 2 times. Okay, in C and T category, A and B are coming under mild categories. So based upon this only we are planning the management. In case of A, the initial management is there is no primary management, but in case of the patient is having any severe cases, we are going to give them short long acting muscarinic agonist along with the long acting beta dilator. Long acting bronchodilator. Next, in alternative management, we are again going to give them a long acting beta agonist and your long acting muscarinic antagonist. When they are coming into the severe category, we are going to give them LAMA, that is long acting muscarinic agonist with an additional treatment, alternate treatment. When the things are persisting, then we are going to give long acting beta agonist and long acting muscarinic antagonist, or again your long acting beta agonist plus your inhaled corticosteroids. D case, which is the severe case where we are going for triple management, that is your long acting beta agonist, long acting muscarinic antagonist, or your long acting beta agonist plus your inhaled corticosteroids. And here additionally the same concept with your roflumilast. Okay. So the example for beta agonist, SABA and LABA, that is your salbutamol and formoterol. Muscarinic antagonist, that is your ipratropium and tiotropium. Inhaled corticosteroids, it is your budesonide, okay, budesonide and your fluticasone. And PDE4 inhibitors, that is your roflumilast. And LOX inhibitors, that is your Xylotone. And your leukotriene receptors, mast cell stabilizers, or the other additional components which you administer for these patients. So next, pulmonary rehabilitation we are doing. So when the patient is having less symptoms and it is manageable, we are going for exercise programs and breathing exercise to this patient. Okay, when the patient is coming of heavy smoking present with chronic cough, already the patient is having a history of smoking. Okay, already the patient is having a more history of smoking, and he is having a chronic cough and sputum production. Whenever we came to the conclusion by seeing the symptom, he's a smoker and he's having chronic cough and sputum production, and on examination he has cyanosis, rhonchi and increased bronchovascular marking on chest x-ray. So which type of COPD is most likely to happen? Yes, now tell me the answer. Which type of COPD is the answer for this? Either emphysema, chronic bronchitis, bronchial asthma, or it is bronchiectasis. Yes, I want everyone to actively answer. As of chronic bronchitis is the correct answer. Why chronic bronchitis? Already the patient is having the smoking history. He is having chronic cough, sputum production. On examination, he is having cyanosis. And cyanosis, again, you have to think about blue blotters. Obviously, blue blotters is your chronic bronchitis. And increased bronchovascular marking, which is a chest x-ray finding classically, we were telling, that is very important to note. And one more thing, the lung sound, rhonchi, is seen in chronic bronchitis. Just remember, chronic bronchitis, the patient will be having rhonchi. The patient will be having rhonchi because of the chronic bronchitis. On the other hand, if you talk about emphysema, now tell me what respiratory sound the patient will be having in case of emphysema. Emphysema, okay, emphysema, just remember the patient will be having wheezing. Now answer me. Increased DLCO is the diffusion, okay, diffusion capacity of the lung for your carbon monoxide, which is the test which is conducted in order to identify the proper capillary and alveolar perfusion of oxygen exchange. So as we discussed earlier, in case of emphysema, that particular value is going to decrease, not at all increase. Value is going to decrease, not at all increase. That particular value is lungs. No, it is a hyperinflated lungs. Decreased diaphragmatic excrusion. Obviously, the diaphragmatic excrusion is decreased. Yes, we have seen about this. According to Gold ABCD classification of COPD, which group should receive LABA plus LAMA as a first line treatment? Now give me the answer. Which group should receive LABA plus LAMA? So to have a quick review, let me go to that particular slide. Now you can answer which particular thing is having the first primary management of LABA plus LAMA. Obviously, it is group D. Here, this triple therapy is done here only. Group D is the correct answer. Okay. LABA plus LAMA is given in case of your group D, that is the severe form of your chronic obstructive pulmonary disease. So next, which of the following pulmonary function test findings is diagnostic for COPD as per Gold's criteria? Now answer me: medicos, meliorism, MUVA, everyone? Yes, I'm waiting for the answer. FV1 FVC ratio greater than 0.8, it is normal. It is a normal finding. FEV1 FVC ratio less than 7, it's correct. FEV1 80%, no, these are all incorrect. FVC alone less than 70%, no. This is the classical primary decider of your COPD diagnosis. So this is the answer. Next, tell me, a 68 years old male with the history of emphysema is observed using pursed lip breathing during mild exertion. Which of the following best explains the primary physiological benefits of this breathing technique? As I said, you emphysema patient, which means I try to breathe, prolong my expiration and reduce the action of workload. Okay, so thereby I am increasing the positive end expiratory pressure to maintain the airway patency in the normal format, even though my lung is hyperinflated. So in COPD patient, Hoover's sign is indicative of which pathophysiological change? Now tell me, Hoover's sign is indicating which pathophysiological change? Hoover's sign is indicating your pleural effusion, no. Diaphragmatic paralysis, no. Always whenever you think about Hoover's sign, think about your flattening of the diaphragm due to hyperinflation. Okay. Flattening of the diaphragm due to hyperinflation. Flattening of the diaphragm due to hyperinflation. This in turn causes Hoover's sign. So next, identify the ECG. The same ECG which I have given in the class has been depicted here. Now tell me, ECG which I have given in the class has been depicted here. Now tell me what is the correct answer. Video is getting interrupted. To a 62 years old smoker who presents with progressive dyspnea, which is most likely the diagnosis? Answering it as a C? Or are you answering for the chest X-ray MCQ or other MCQ? I think you people are answering for the previous MCQ. I am asking about this MCQ. Like, what is the following chest X-ray belongings of 62? As you see, there is an hyperinflation of the lungs, which indicates emphysema. So B is the correct answer. Which of the following drug used in COPD act by increasing the intracellular cyclic AMP and causes bronchodilation? Yes. COPD patients will receive salbutamol. Okay. The ultimate action of that salbutamol is by increasing the cyclic AMP and causing bronchodilation. Okay. So next, which of the following is the most common cause of obstructive pulmonary disease? Chronic obstructive pulmonary disease, the answer is your tobacco smoking, because it is a very, very easy MCQ. And next, here we go. A 68 years old male with COPD present with cyanosis, productive cough and peripheral edema. Which COPD phenotype does this suggest? He's having cyanosis, productive cough, peripheral edema. Whenever you see a word cyanosis, productive cough, close your eyes and go and take blue blotters. Pink buffers is also emphysema. Type A COPD is the other name of emphysema. Okay. And blue blotters, chronic bronchitis, or type B COPD. Other names, please note it. To twist you, they can ask type B COPD. Then that is chronic bronchitis. So a COPD patient suddenly becomes restless, dyspneic, and has respiratory rate of 32 per minute, and SpO2 drops to 84 in room air. What should the nurse first do? So the patient is becoming restless, dyspneic, and has the respiratory rate of 32. So what you have to do, notify the physician, increase the fluid intake, apply prescribed oxygen via nasal cannula, encourage pursed lip breathing. So you have to first try to maintain the oxygen saturation level of the patient. So ultimately you have to apply prescribed oxygen via the nasal cannula, which in turn going to stabilize the SpO2 level. A nurse finds a COPD patient with severe shortness of breath and the use of accessory muscles. Which action should the nurse take first? With severe shortness of breath and use of accessory muscles, which action should the nurse take first? Now answer me. The nurse finds a COPD patient with severe shortness of breath and use of accessory muscles. Which action should the nurse take first? Administering, place the patient in high Fowler's position. Yes, it will help in increasing the lung expansion. Administer IV fluids. No, irrelevant. Prepare chest physiotherapy. Irrelevant. Instruct the patient to lie in flat and rest. No, this is going to worsen the symptoms. The correct answer is place the patient in the high Fowler's position. A nurse administering salbutamol via nebulizer to a patient with COPD. Which finding requires immediate nursing action? Heart rate increase from 78 to 95? No. Patient complains of mild tremor? No. Patient reports chest pain and palpitation? Yes. The salbutamol, the drug, is having increased effect of causing arrhythmias. Okay, it has an increased effect of causing arrhythmias. So it is very important to note that the patient, if she is going for chest pain and palpitation, there is a lot of possible the patient might go for any kind of arrhythmia. So it is very important. Productive cough with white sputum? No. Okay, we have come to the end of the session. And sorry, there was a lot of interruption during the session. It's okay. And if you have any query, any scientific query related to your subject, MSN, pharmacology, and nursing management and education, you can connect with me to my social media handle. Do follow and support me. Thank you so much for watching.